Dear colleagues, welcome to our webinar on ethical principles and dilemmas in psychiatry. My name is Meryam Schouler-Ocak. I'm chair of the Committee on Ethical Issues of the EPA. I'm very happy that we could organize this webinar together with the Committee of Early Career Psychiatrists and the Steering Committee of the National Psychiatric Association of the EPA. So we have very expertise colleagues in this webinar. I'm very happy that we could realize this webinar because clinical ethics and consultations in psychiatry is a relatively new field that involves not only ethical reflection, but also support for practice. Its implementation is linked to wishes and hopes, not only of individuals, but also of the institution of psychiatry as a whole. More freedom instead of coercion, help with questions of consciousness, social recognition for work done, the experience of meaning and few value conflicts in dealing with patients. There is a need for promotion of ethical competence of professional groups in psychiatry for our daily work. Therefore, I'm very happy that I can introduce now also the chair of the Early Career Psychiatrists Committee, Özge Kilic, who will be the co-chair of our webinar. Dr. Özge Kilic works in an assistant professor position of psychiatry and teaches in the Faculty of Medicine and the Neuroscience Master's Program at Bezmi Alem Vakıf University, Istanbul, Turkey. She is the chair of the Early Career Psychiatrists Committee, as mentioned, of the EPA, past chair of the Research Task Force of the ECPC, and was the past coordinator of the Trainee Committee of the Psychiatric Association of Turkey. She is a member of the Early Career Psychiatrist section of the World Psychiatric Association. Her current research interests include adult attention deficit and hyperactivity disorder, gender differences in psychiatry, gender equity, comorbidity between mental and physical disorders. I will hand over the chair position to Özge a few minutes later. Now, I'm very happy to introduce our first speaker. It is Professor Silvana Galderisi. I think you all know her. She is full professor of psychiatry, director of the emergency unit of the Department of Mental Health of the University of Campania, Luigi Vanvietti, coordinator of the outpatient unit for anxiety and psychotic disorders, and of the rehabilitation program for severe mental disorders in the same department. She is president of the Italian Society for Psychopathology, past president of the European Psychiatric Association, chairperson of the Standing Committee on Ethics of the World Psychiatric Association, and co-chair of the working group of WPA implementing alternatives to coercion in mental health care. She is a founding member and member of the board of directors of a European group for research in schizophrenia, board member of the European Scientific Association on Schizophrenia and Other Psychosis, and of the Italian Society of Biological Psychiatry. Silvana, you have a lot of other positions. So her research activity focuses on schizophrenia pharmacology, treatment and outcomes, with particular references to the domains of negative symptoms and cognition and their impact on psychosocial outcomes. She has written a lot of publications, scientific publications, national, international, in journals, but also in books. And she's also member of editorial boards of several international psychiatric journals, editor-in-chief of Schizophrenia Bulletin Open. We are very happy, Silvana, to listen now to your talk on EPA Code of Ethics, the EPA perspective. The floor is yours.
Thank you very much, Meryam, and thanks to all the colleagues that are joining this webinar. I think this is a very important initiative, and I'm very pleased to be part of it because I think that this is really a field in need of more attention by all of us, and especially young psychiatrists. Thank you also, Meryam, for your kindest introduction. that is there to tell you how old I am in order to do all of this and achieve this position. So that's all. Thanks a lot. I will now share my screen. The title of my presentation, as Professor Schouler-Ocak already mentioned, is the EPA Code of Ethics, the WPA perspective, meaning that in this presentation, I will try to highlight similarities, but especially differences, which are minor, certainly very minor, between the two codes of ethics. This is my disclosure slide, which I think is very important, especially when talking about ethical issues. It's nothing that has anything to do with this presentation, but still is very important to be disclosed. So I will introduce the topic by reminding all of us who is WPA and who is EPA. The World Psychiatric Association is a global association representing 145 psychiatric societies in 121 countries, bringing together more than 250,000 psychiatrists. The reason why I'm highlighting also these differences is because most of the differences, most of the discrepancies between the two codes of ethics are actually explained by the different nature of the two associations. One is a global one, so covering many countries with a wide range of cultural backgrounds, whereas the European Psychiatric Association, that anyway includes many countries, 88, and 44 National Psychiatric Association members representing more than 80,000 European psychiatrists, and therefore limited to the cultural context within Europe, which is heterogeneous enough. I can tell you from my experience also as the president of European, past president of the European Psychiatric Association, and in dealing with the National Psychiatric Association within the European Psychiatric Association, there is quite a lot of heterogeneity, but certainly more in WPA. The WPA Code of Ethics has a very, very long history, the current one, I mean. It was approved recently, 2020, by the Virtual General Assembly, because in 2020, of course, a Congress in person was not possible, and therefore the General Assembly took place as a virtual one. I have to tell you that I can testify that it was a very difficult way, the one that the WPA Code of Ethics had to go through, because to get the agreement, to achieve an agreement among the different National Psychiatric Association was a very, very hard task, much harder than in the European Psychiatric Association. Actually, the first draft that was ready for, let me say, a discussion within WPA and the General Assembly, the discussion went on for several years. I was a member at that time of the committee, and finally was presented to the General Assembly in Berlin in 2017. And then it still underwent several more revisions. A final version was then approved by the Executive Committee in September 2019, following previous efforts of having a shared Code of Ethics represented by the Declaration of Hawaii in 1977 and of Madrid in 1996. European Psychiatric Association approved in its General Assembly the Code of Ethics on April 2021. So I can tell you that both Code of Ethics are rather young in terms of age, and therefore they are quite well aligned with the current needs in terms of ethics. And I can also tell you, as I already mentioned at the beginning, there are no main discrepancies. The organization of the EPA Code of Ethics, of course, will be reported by Meryam, and therefore I will not deal with it, only will remind ourselves that it is divided into several paragraphs covering the important topics. whereas the WPA Code of Ethics is divided into sections, 4 sections: ethics in the clinical practice of psychiatry, in psychiatric education, in psychiatric research, in public mental health. As to the ethics in the clinical practice of psychiatry, it is also subdivided into 5 overarching principles, which are the ones that actually were the main focus of discussion among the WPA member societies. And finally, an agreement was reached on these 5 principles: beneficence, respect for patients' autonomy, non-maleficence, improving standards in practice, applying expertise to the service of society. The last 2 ones are reported in italics because of the fact that they are not fully shared or at least clearly reported as principles in the EPA Code of Ethics. But by the way, they are covered by the wording in which the different principles are described also in the EPA Code of Ethics. Now, one of the issues discussed for the approval of the WPA Code of Ethics, of course, was relevant to the problem that when, let's say, the overarching association is proposing a code of ethics to the member societies, this code of ethics has to be compatible with the national codes of ethics. And this was the main, let me say, concern of the different national psychiatric associations, that is making sure that there was no main conflict, that the overarching code of ethics was actually leaving enough room for the member societies to feel free to keep their own code of ethics. Of course, the national code of ethics are binding on the members of the national associations, and member societies are asked to endorse the 5 principles embodied in the WPA Code of Ethics and confirm that their codes are not in conflict with them. So, as a matter of fact, the most important, as I said, was the discussion relevant to the 5 principles, because those were considered as binding for member societies and for the members of the member societies. Each endorsed principle is enumerated in bold. Of course, as we saw, the principles are followed by number annotations, and member societies that are developing or revising their codes are encouraged to consider the code as guidance in that process. This is what is reported in the current WPA Code of Ethics before listing the 5 principles. Let me briefly highlight one of the points that has been discussed in details in the committee and that is not reported in many other Code of Ethics. One point included in the first principle, beneficence, that says that psychiatrists provide competent and compassionate medical care with devotion to the interest of the patients, and has one point saying that they also advocate for patients' interest in the receipt of appropriate psychiatric care and respect of human rights, including reproductive rights. I think that for our women patients, this is an extremely important point. I mean, for many of us, especially in Europe, this appears like something obvious, but I can tell you by experience that this has not been the case always everywhere. And as a matter of fact, there have been countries in which WPA Congress had to be cancelled for the lack of respect of this principle. As to compulsory treatments, the 2 Code of Ethics, WPA and the EPA, are quite well aligned. There is just a subtle difference, meaning that in the WPA Code of Ethics, the main reason reported for compulsory treatment to be justified is where a less restrictive intervention cannot achieve adequate care. In the EPA Code of Ethics, it is also clearly reported that the compulsory measures can take place when the patient is a risk to themselves or others. So this concept of risk for themselves or others is not present in the WPA Code of Ethics, as well as, for instance, in the Italian law relevant to compulsory treatment and in other laws too. In addressing the media, WPA has the accent on the, let's say, goal to educate the public, meaning that psychiatrists should offer accurate information to the media, not for, let's say, having visibility, as it often, unfortunately, happens, but to educate the public about the nature, the consequences of psychiatric disorders and their treatment, to dispel misconceptions about people with psychiatric disorders. And in the EPA Code of Ethics, there is an additional point, which is, in my opinion, extremely valuable, that is also relevant to the goal of preserving the dignity of psychiatry as a profession. As to assisted suicide, here too we have some subtle differences, because in the WPA Code of Ethics, it is reported that psychiatrists avoid endorsing patient requests for implementing termination of life-sustaining treatment or physician-assisted death when they recognize that underlying psychopathology drives those requests. So the task of our colleagues, of ourselves, is to try to connect the request to an eventual underlying psychopathological disorders. In the EPA Code of Ethics, there is something more, because there is a sentence referring also to the protection of life, so to the Hippocrates binding request principles for our profession, and therefore it is also telling all psychiatrists of their need to think in terms always of protecting life. So this is not different in terms of consequences, but it's different in terms of principles. So it makes what is reported in WPA also based on what we have as a duty when starting our profession in terms of binding principles. And so the psychiatrist should be aware that the views of a patient may be distorted by a mental illness. And so the duty is to treat the illness and not be, let me say, only guided by the legislation, but also by our professional standards. The death penalty, and here comes to the point, I come to the point where, of course, the different nature of the two associations that I referred to in the beginning of my presentation justify some differences, because, of course, in the EPA Code of Ethics, this section is missing, because up to now, the death penalty is not a matter of concern in our continent. But for WPA, it's very important to state that as physicians who are committed to sustaining and improving people's lives, psychiatrists do not participate in the administration of the death penalty. As to the use of psychiatry for political purposes, once again, you can see that there is a larger paragraph in the WPA Code of Ethics and in the EPA one. Once again, because the abuse of psychiatry for political purposes or torture has been an experience in more countries outside Europe than in Europe. As to the psychiatrist-patient relationship, the two code of ethics are very much aligned. Psychiatrists respect the boundaries of the clinical relationship, and even the wording here is very much in overlap. With third parties, here too, we have several similarities, certainly more similarities than differences, because WPA says that psychiatrists avoid engaging in relationships with third parties, including but not limited to the pharmaceutical industry, that may compromise their primary focus on the interest of their patients. Financial relationships should always be disclosed. For EPA, psychiatrists need to ensure that the patient's health is the main focus, need to ensure patients receive the best treatment. Even this may sometimes conflict with third-party payers and organizations which concentrate on their profits. Discrimination is taken care of in both code of ethics. And for the WPA code, psychiatrists respect patients' culture, ethnicity, language, and religion. They do not discriminate on any grounds, including age, sex, gender, race, ethnicity, sexual orientation, disability, language, religious or political affiliation, socioeconomic status. Neither do they attempt to impose their own values on patients and patients' families. Very similar in EPA code of ethics. The education in WPA has a quite large section about education, explaining the psychiatrist's role as teachers, educators, and mentors. The section is missing in the EPA code of ethics, and we should probably go back to this point and have a discussion in the committee relevant to this aspect. As to psychiatric research, once again in WPA, the topic is more extended than in the WPA, than in the EPA code of ethics, but once again, the two code of ethics are very compatible. Research should comply with the values of beneficence, non-maleficence, respect, and so forth, the principles that I highlighted before. We should always obtain approval from independent ethics committee, undertake only research design that is within the scope of our competence and resources and likely to yield meaningful data. I think this is something that is not always adhered to in terms of psychiatric research. In my opinion, this is not always the case, but still it's not always easy to deal with this principle. Should seek appropriate informed consent procedures, of course, disclose the sources of funding, other potential sources of bias, avoid relationships that would compromise research and publication, and disclose relationships that may constitute a conflict of interest. EPA covers this aspect, and I think that Meryam will go through, but I mean, as I said, there is no discrepancy, but is less detailed. The other aspect relevant to stigma, for WPA psychiatrists take every opportunity to combat the stigma related to psychiatric disorders in their practice. For EPA, should work at different levels to promote public mental health and well-being, as well as decrease stigma and discrimination. So you see that here there is also reference to the public mental health while dealing with the issue of stigma. Equity, psychiatrists should seek equity in prevention, treatment, rehabilitation. For EPA, obligation to advocate for universal care, fair, appropriate prevention, care, treatment, and rehabilitation. As to the aspect relevant to public mental health, as I said here, the chapter in EPA is shorter because public mental health is mentioned in other specific aspects, for instance, stigma. But for WPA, psychiatrists should participate in public education, raise public awareness, promote distributive justice, and the development of rehabilitation services. This, I think, is my last slide. This is to make my chairperson more aware of the fact that I will not abuse my time. I think that this is an important aspect that should be covered in all code of ethics. Psychiatrists are aware of the deleterious consequences of family violence, emotional, sexual abuse on mental health and well-being, especially for women and children, and they work to minimize the occurrence of violence within families. So this is an important aspect to be always taken care of. And with this, I end my presentation. Thank you very much for your attention. Thank you.
Silvana, thank you very much for this very comprehensive overview on similarities and differences in the Code of Ethics of WPA and EPA, and presenting us the perspectives from the WPA view. Thank you very much. Just to mention to the audience, please insert your questions and comments to the Q&A button via using the Q&A button, and we will get back to you by the end of all presentations. So I think at 4:30 we will be finalized with our presentation and get into the part of discussion with you. Thank you very much. Just another information. We have 241 registrations. This is quite a very good number. Thank you very much for your interest and joining us. Please get back to us with your comments and questions. So I'm handing over the chair position to Özge now.
Thank you very much, Meryam. I am very honored to chair this webinar with dear Meryam Schouler-Ocak within the collaboration of Committee on Ethical Issues, Early Career Psychiatrists Committee of EPA, and the National Psychiatric Association Steering Committee. I think this ethics webinar is a very important initiative that stresses the importance of code of ethics in psychiatry for all psychiatrists, but also early career psychiatrists. And I am very honored and pleased to introduce dear Meryam Schouler-Ocak. She is a professor of intercultural psychiatry and psychotherapy, and she is also a specialist for neurology, psychotherapy, particularly in trauma-focused psychotherapy and EMDR therapy and social psychiatry. She is the head of research area on intercultural migration and care research, social psychiatry at Charité University Berlin. She is a board member of European Psychiatric Association, chair of Committee on Ethical Issues of EPA, chair of section on transcultural psychiatry of World Psychiatric Association, and board member of the World Association of Cultural Psychiatry. She is also the chair of section of intercultural psychiatry and psychotherapy, migration of German Association of Psychiatry. She is also the chair of working group of providing mental health care for migrants and refugees for working group action plan of WPA. And Professor Schouler-Ocak received the Order of Merit by the Federal Republic of Germany on 2014. And her research interests include intercultural psychiatry and psychotherapy, trauma and trauma-related disorders, mental and health care of immigrants, refugees, asylum seekers, and ethnic minorities, suicidality and diversity. We are very looking forward to listen to her presentation on ethical principles and dilemmas in psychiatry. Please, Meryam, the floor is yours.
Thank you very much, Özge, for this very honoring introduction. My presentation will be on EPA Code of Ethics, Ethical Guide for European Psychiatrists within this webinar. Thank you very much again. So this is the composition of the ethical committees of EPA in 2020, which worked out the Code of Ethics of EPA on the chairship of Danuta Wasserman. And this is the current Ethical Issues Committee composition since 2021. So I'm chairing now it, and you can follow or see that we have members in our committee from different parts of Europe, for example, from Georgia, from France, Italy, Austria, Germany, Israel, Turkey, and Netherlands and UK. This is a snapshot during a meeting which we had online, and not all of the members of our committee were at that time present. So it's a very nice atmosphere in our committee. Now starting with my topic, Silvana has also reported the binding to Hippocrates, and Hippocrates once said the physicians must be ready not only to do his duty himself, but also to secure the cooperation of the patient, of attendants, and of externals, so relatives and so on. And the psychiatry is, of course, a specialty in our professional life of medicine, and we should own codes of ethics, often formulated by learned members of the group of professionals. And these codes of ethics are recognized as standards of professional conduct by which acts are judged. And from a public perception, these do not necessarily provide a comprehensive or even substantive account of what is to be an ethical psychiatrist. Now looking to the Code of Ethics, as mentioned by Silvana, it is approved by the General Assembly last year during the EPA Congress during the EPA Congress, which was online. And you can download it via this app or link. So now going on with the fundamental values, we psychiatrists must uphold the responsibility which we have and ethical demands of the medical professional, and specific to, of course, psychiatry and working with mental health. We should consider the ethical principles, as mentioned by Silvana, of respect for autonomy, of course, dignity, beneficent, non-maleficent, and treat people fairly. These practicing ethical psychiatry requires, of course, awareness, sensitivity, and empathy for our patients as an individual, of course, including their cultural values, beliefs, explanatory model, expectations, and so on. We have the obligation to advocate for universal healthcare for everyone and fair and appropriate prevention. It was also reported by Silvana, care, treatment, and rehabilitation for persons with mental disorders within available resources in their respective country, in the countries where these patients are living. And we shall not discriminate on the basis of age, for example, or race or ethnicity, nationality, religion, sex, gender, sexual orientation, social standing, criminal background or disability, disease, or political affiliations. We should treat our patients fairly. We must never endorse and participate in discriminatory actions, which was also underlined by Silvana. And we must stay respectful in our communications with our patients, but also relatives and staff. Furthermore, we shall not act as proxy decision makers for our patients and need to stay respectful of our patients' decisions and ensure our patients' rights to express their will, for example, in cases of coercion, restraints, compulsory medication, and other issues. We should inform patients about their diagnostic and therapeutic procedures, promote their autonomy, and always seek their informed consent. This is very important. If we can't communicate with our patients, we should use, for example, in case of immigrants or refugees, qualified interpreters. I think this is a duty to get the information and to get the informed consent of our patients, and to be able to do shared decision-making processes. We psychiatrists should promote education of our patients, of course, families and other professionals, to empower decision-making processes, to inform our patients, for example, in psychoeducational issues and so on. Furthermore, we have a responsibility to ensure the knowledge and praxis, our knowledge and praxis, and we should be up to date through continuing education, visiting, of course, congresses or webinars like this one, or doing publications, scientific publications, and so on. And we should be aware of the best available treatments for our patients in their respective countries. We should maintain therapeutic boundaries. We have a lot of patients, sometimes they come with a lot of presents, or they would like to be a friend of us, or sometimes they are also misused as workers in the garden of colleagues, or I don't know where else. This is not allowed. We have to maintain our therapeutic boundaries. And we have to guard their health and mental well-being and seek help when necessary. Support them in these issues. And looking to providing individualized care, we should advise evidence-based treatment and try to secure the best available and suitable treatment for our patients, even on rare occasions when this might be parallel to wishes from the societal level. We should stay professional and work in evidence-based treatments processes. In communications with our patients, we should be able to understand our patients, to overcome, as mentioned before, language or cultural bounded barriers, in addition to ensure to giving security, attention, and in time, according to the patient's condition within available resources. For example, again, underlying respect for autonomy and dignity, gravely ill or disabled patients, involuntarily, for example, compulsory care and treatment issues, and we should be confidential. We have to maintain confidentiality. A careful approach to timing, for example, or duration are proportionally, and patients' understanding of coercion measures can allow staff to promote the dignity of patients undergoing coercion care. For example, the sense of powerlessness experienced by our patients can be seen as a threat to their subjective dignity, as dignity violations are more likely when our patients are in a position of vulnerability, in a powerless position. Staff as well as patients describe these ambivalence regarding house rules. We all have in our wards and hospitals and so on, our rules in our settings and so on. Some regarded them as humiliating or condescending, acknowledging the unequal power relationship between staff and patients, between medical, also doctors and patients. Lasting impact of admission, both on patients' trust in the health services and on their social and family life, also emerged as a theme. We should be aware of these issues, recognizing that patients may be subjected for stigma or discrimination or internalized self-stigma following an admission is not new. We should be aware of this, and we should talk to our patients and discuss it with them, and there is less research on this issue. Still, now looking to the topic, be psychiatrists as researchers. Of course, good practice in research demands that the research always ensures, again, beneficial, normal, efficient, integrity, of course, informed consent, and that people's rights and dignity and respective national, of course, medical association guidelines are respected. The guidelines could be very different from country to country. We should be aware of it. Exploitation of patients and particular population groups, for example, by sex, ethnicity, nationality, occupations, and so on, could be avoided under all circumstances. Sorry, not should, could be, and we should do it. Potential harm that may be physical, for example, or psychological, or cause discrimination and stigma needs to be analyzed in each project and must be avoided. We shouldn't ignore such kinds of processes. We should focus on it and try to avoid it. Research needs to be conducted under, of course, ethical approval of a governing body in the respective country that is represented in the EPA. In Germany, for example, of course, our university had also an ethical committee, and we always receive ethical approval by our committee before starting research projects and so on. And research must ensure confidentiality, of course, of results. This includes securely storing and protecting data from unauthorized personnel in accordance with general data protection from in regulation law in Europe. We should always disclose the source of funding for research and any collaborations as done by Silvana. Now, addressing the media, we have a very responsible position here on duty. We should conduct themselves and present information which we have in a way that will preserve the dignity of psychiatry as a profession, subjects and topics pertaining to psychiatry, psychiatrists, and persons with mental illness. Of course, we need to ensure that information on research and findings is accurate and prevent statements made from misunderstanding. We should take into consideration that caution should be realized to avoid discrimination and stigmatization of individuals with mental health problems, our patients. We shall not break the medical confidentiality laws of our countries, and we shall conform to the specific libel and slander requisite within our respective countries. Our relationship with industry should be also open and discussed. We need to disclose affiliation with supporting or collaboration organization, but also financial supporters. It is very important for us to ensure that any incentives from sponsors do not influence, of course, our professional work and in turn, the health of our patients. Furthermore, we can have also relationships to third-party players. For example, we need to ensure that the patient's health is the main focus and need to ensure patients receive the best treatment possibilities. If some medications are too expensive and it is good for our patients and it is the best, we should use this treatment possibility. This may sometimes, of course, conflict with third-party payers and organizations which concentrate and maximize their net profit. So by insurance companies, for example, it's sometimes very difficult to get the cost for it, but we should try our best. As such, it is important for us to uphold the UN resolution of the principles of the protection of persons with mental illness, which states that psychiatrists, we should oppose discriminatory practices with limit their benefits and entitlements, deny parity, curb the scope of treatment, or limit their access to proper medications for patients with a mental disorder. So there are also specific situations which were also mentioned by Silvana. So torture, for example, we psychiatrists must not take part in these kinds of processes, of course. And for example, selection of psychiatrists, we should not participate in these decisions processes, for example, to terminate pregnancy for the purpose of sex selection. There are also other specific situations, for example, assisted suicide. We physicians have the duty, first and foremost, to promote health, to reduce suffering, and to protect life. And we psychiatrists, among those patients, are some who are severely incapacitated and incompetent to reach and informed decisions, should be particularly care of actions that could lead to the death of those who cannot protect themselves because of their disability. So we should be aware that the views of our patients may be distorted by mental illness. So our role is to treat the illness. We psychiatrists should not only be guided by the legislation in our countries, but also by the standards of the professional organizations. And it is not our duty to take part in assisted suicide. So there are also health guiding principles for decision-making about life-sustaining measures. For example, principle 1, all decision-making must reflect respect for life and patients' right to know and to choose. All decision-making must meet the standards of good medical practice, psychiatric practice. All efforts must be made to obtain the appropriate consent through a collaborative approach, decision-making processes, respect, and so on. There must be transparency in and accountability for all decision makings, and so on. So the EPA Committee on Ethical Issues is responsible for giving its contribution to the EPA position statements on ethical subjects, if there are some, collaborating with, doing now in this webinar with the National Psychiatric Associations to promote ethical standards in psychiatric research and care, and organizing events like this one or during our congresses and so on.
Thank you very much. I am very pleased to introduce our third speaker, Dr. Przemyslaw Bienkowski. He is a medical doctor and doctor of philosophy. He graduated from the Faculty of Medicine, Medical University of Warsaw. In his early career years, he specialized in psychopharmacology, working in the Department of Pharmacology, Institute of Psychiatry and Neurology, Warsaw, Poland. From 2016, he holds a position of Professor of Psychopharmacology in the Department of Psychiatry, Medical University of Warsaw. His recent scientific interests concentrate on atypical manifestations of serotonin syndrome, overactive bladder, and rare side effects of clozapine. He is the main author of, or co-author of more than 130 papers published in peer-reviewed medical journals. Dr. Bienkowski is the former chair of Local Ethics Committee and a member of the Executive Committee of Polish Psychiatric Association. Please, the floor is yours.
Thank you very much. Thank you very much. Thank you for inviting me. Thank you, Meryam. Thank you, everybody. So, welcome, everybody. Good afternoon. I would like to present a kind of teamwork, a result of our activity within the NPA working group, and the members of working group are on this slide. I would like to say thank you to Jerzy Samochowiec, who organized the whole activity and supported this activity from the perspective of NPA. My conflict of interest can be seen here, so I declare all related and unrelated. Be sure that 100% of my conflict of interest is unrelated to this presentation. And the scope of our activity can be seen here. We still would like, but we also wanted to compare NPA's procedures and practices addressing basic ethical issues specific to psychiatry. So the question was how we do it, how we deal with ethical dilemmas within European psychiatry, whether we recognize and implement international ethical codes. These ethical codes, very basic ethical codes of WPA, EPA, were already mentioned by Meryam and Silvana. We also wanted to identify emerging ethical issues for Europe-wide discussion right now and also for future EPA, NPA activities. We also wanted to assess some basic willingness of NPAs to exchange practices to build a common European database of ethical documents. We received 31 official answers. This is very important, official answers from NPAs. And here you can see the list of NPAs. In the case of Russia, we received 2 responses because there are 2 separate psychiatric associations over there. And in part 1, I would like to review existing documents and practices. Existing, that means something that NPAs already had from autumn 2021 to spring 2022, when these data were gathered. What internal documents does your association have that address ethical issues specific for psychiatry? This is a question which was included in the questionnaire, so I do not review the whole questionnaire, but at least you have a correct, exact wording of questions included in the questionnaire. And less than 30% of NPAs declared they have separate ethical code. It is not very surprising because one may expect that most NPAs would rather be willing to adopt international ethical codes or to use just general ethical codes available for all medical doctors. General mission statement was the most popular kind of document. This is only a kind of document specific to ethics in psychiatry. More than 70% of NPAs declared they have some statutory bodies dealing with ethical issues like ethics committee, peer tribunal, panel of ethics, or many other specific solutions adopted by specific NPAs. So I would say more bodies than documents exist in European psychiatry considering ethical dilemmas. What kind of ethical issues are specifically addressed in your internal documents? So in these documents existing, medical malpractice was a mostly addressed topic, at least considering member-member relationship, because we have divided these topics addressed in internal documents to those related to member-member relationships, and their medical malpractice was the most popular topic mentioned, and also to patient-member relationship. And here again to the left, I would like to pay your attention to the left. Again, medical malpractice was the most important topic considering patient-member relationship, also malpractice in psychotherapy, but also discrimination and racism. Specific potentially controversial procedures addressed, that was a question related a little bit to our own situation in Poland. We came through a hot public debate considering pregnancy termination, but also this debate was related to the participation of psychiatrists in pregnancy termination. This is why at least Jerzy and me, we were interested in checking whether there are some documents all over Europe which could address this specific problem, but also whether there are other documents addressing other problems. So you can see that, for example, 3 NPAs have some documents related to euthanasia, 2 NPAs have some specific guidance related to pregnancy termination. That was not surprising. I would say I would expect something like that. The picture you can see on the next slide, that most NPAs were open to international ethical principles, international ethical guidelines. So this is not surprising, I think, in all over medicine, that medical doctors are generally prepared to accept some international codes and regulations. Of course, there was also a possibility to check both internal and international. This is why 23 plus 25 is something more than the number of NPAs participating in the survey. As your NPA formally adopted any international ethical codes, that result was a little bit surprising. So 11 NPAs declared they adopted WPA Declaration of Madrid, but only 6 NPAs adopted EPA code. Of course, EPA code is younger. This document is relatively young and relatively new for European psychiatrists, so there is still some room for promoting this issue. And I have talked a lot with Meryam, with Jerzy also, that we should altogether promote the recognition of EPA code, but also the validity and importance of EPA code for European psychiatry. Declaration of Helsinki was also adopted by 11 NPAs. This is also, I think, not very much surprising. This is something like a result of the whole hot debate we had 10, 20 years ago around the relationship between medicine and research, between medicine and industry, and between medicine and big pharma more specifically. NPAs are generally open to cooperation in the area of medical ethics. NPAs are generally open to sharing ethical documents, but also open to participating in building EPA-supported database. This is something, I think, for the future, for maybe even next generation, to produce a kind of EPA-supported database of ethical documents, ethical guidance existing in Europe. So conclusions from part one: NPA are active in the field of medical ethics, prefer building committees. This is our impression, rather than preparing documents. NPAs are generally open to adopt international ethical codes, like Declaration of Helsinki, for example, but the EPA code is still to be formally adopted by most of NPAs. And the third conclusion: most NPAs accept the idea of sharing their ethical document and building EPA-supported database of ethical guidelines. Result part two. I decided to divide my presentation into part one, part two, because part two is a little bit tricky. This is something I would say less obvious or less scientifically valid, because this is a kind of quality analysis of open-ended questions on ethical dilemma for current and future debates. And of course, we do not have a huge number of answers. So the statistical analysis you will see in a moment should be treated as a preliminary starting point for more in-depth analysis in the future. So we used, for example, some categories which were used for a more in-depth statistical analysis of the answers from the quality analysis. We used number of psychiatrists, for example, in a country, suicide mortality, or gross domestic product in bold in the middle on the left, and West-East dichotomy according to political boundaries dividing Europe 30 years ago. This West-East dichotomy may be criticized, this iron curtain concept may be criticized, but it's still a very simple way to divide European countries, at least according to a kind of political tradition. Still, I think, valid considering some local fashions or local ideas or local political tradition. What ethical dilemmas do you consider recognize the most important topic for debate in your NPA? Left top part of the slide. So in other words, what ethical dilemmas do you consider the topic for debate right now? And you can see on the left examples of responses, and on the right, what ethical dilemmas do you foresee as the most important topic for debate in the years to come? And again, a list of quite popular answers we have found in the questionnaire. Okay, so of course, for obvious reasons, some clustering of NPA responses was critical. Considering any statistical analysis, we had to cluster NPA responses, and we proposed through a specific but also well-balanced and controlled procedure, we propose 4 major clusters: violation of clinical practice standards, or in other words, medical malpractice, human rights, involvement of psychiatry in potentially controversial procedures, stigmatization, discrimination, access. This is a cluster number 4. And in the cluster number 5, we included all other responses, mostly with n just equal to 1. So here are specific data, specific results from this clustering. So after clustering NPA responses, considering topics for current debate and activities, human rights is number 1. So the cluster number 2, human rights, is number 1, but the responses here distributed pretty equally. So violation of clinical practice standards, stigmatization, but also number 3, involvement of psychiatry in potentially controversial procedures, received pretty much attention from NPAs. Considering topics for future debate and activities, just pay your attention to the top of the slide. The slide before was dealing with current activities, and here you can see topics for future debate and activities. Again, cluster number 2, human rights, was the most popular as a topic for future debate. Followed by number 4, stigmatization, discrimination, access, but also some attention given to involvement of psychiatry in potentially controversial procedures and violation of clinical practice standards. And here I go back to some categories or some other characteristics of countries of origin for a given NPA. And for example, on the left, you see gross domestic product as a function of indicating category medical malpractice. So taking that pretty simple, without going to details, a medical malpractice was indicated more often by countries with lower gross domestic product. So in a very, very, very general sense, poorer countries indicated more often medical malpractice as a topic for current debate, as a topic for current ethical debate in psychiatry. On the other hand, involvement of psychiatry in controversial procedures was more often indicated by countries with higher gross domestic product, what you can see on the right side of the slide. Indicating category of medical malpractice was also more common within countries traditionally included in a group of Eastern European countries. So considering this old dichotomy of Iron Curtain, Eastern European countries indicated more often category medical malpractice as a topic for current debate. And Western European countries indicated more often involvement of psychiatry in controversial procedures, what you can see on the right side of the slide. One may ask, of course, what kind of controversial procedures were indicated, and this is why I added some information on the right side in the bottom. Mostly euthanasia and assisted suicide. These were the controversial procedures mentioned by Western European countries. So I would say that medical malpractice is a major topic for debate, one of major topics for debate in Eastern European countries, and at least our data may suggest that controversial procedures like euthanasia or physician-assisted suicide is a controversial and hot topic for debate in Western European countries. And let me conclude from part 2, human rights, stigmatization, discrimination, access, medical malpractice, and involvement of psychiatry in controversial procedures are 4 major ethical dilemmas, or are 4 major clusters of ethical dilemmas indicated by NPAs in open questions for current and future debate. Welfare and geography still matters when discussing ethical dilemmas in European psychiatry. And last but not least, research and industry-related issues are not recognized by NPAs as major problem for current or future discussion. Just let me comment a few seconds on the last topic. Declaration of Helsinki, I think, was adopted by many NPAs on the basis of a debate we faced 10 or 15 or even 20 years ago, debates related to the conflict of interest, industry-related issues, big pharma infiltrating medicine all over the world. But right now, at least looking at this data, research and industry-related issues are not the hottest topics for debates indicated by NPAs in our survey. Thank you for your attention.
Thank you very much, Dr. Shemek. You showed us the findings of NPA EPA questionnaire on ethical dilemmas in contemporary psychiatry, and you stressed the importance of topic of current and future ethical debates in European psychiatry in open questions, which is it's a free area to express the thoughts. These are violations of clinical practice standards and medical malpractice, human rights, involvement of psychiatry in potential controversial procedures such as euthanasia and assisted suicide, and stigmatization, discrimination, and access. Thank you very much for mentioning, talking about these controversial issues, which I think can have a basis for our discussion. Thank you very much.
We are going in our program on, and I would like to ask you for questions and comments. If you have some, please use the Q&A button or chat to get back to us. We have time after our next presentation to discuss with you. So I'm very happy now to introduce our next speaker. It is Professor Jerzy Samochowiec. He is a professor of psychiatry, certified psychotherapist, and the chair of the Department of and Clinic of Psychiatry at the Pomeranian Medical University in Szczecin. He is chair of the Steering Committee of National Psychiatric Association, president of Polish Psychiatric Association till this year, a vice rector for scientific affairs of Pomeranian Medical University, and he is also editor-in-chief of Archives of Psychiatry and Psychotherapy, member of the editor board of Progress in Neuropsychopharmacology and Biological Psychiatry. Furthermore, he is member of the board of directors of European Society of Biological Research of Alcoholism, ESPRA project, and he is also author of a lot of scientific papers, more than 400 I read here, and has a huge impact factor and Hirsch index and so on. And his main scientific area of interest includes genetics and addictions, depression, anxiety disorders, ADHD, pharmacogenetics of schizophrenia. So you are very, very competent in huge area, Jerzy. So we are very happy to listen now to your talk on policy of open door psychiatry and minimization of the use of direct coercion measures. So, Jerzy, the floor is yours.
Thank you very much for a nice introduction, Meryam. Thank you very much for joining our joint session. It's so good that Ethics Committee and Ethics of Early Psychiatrists and the Council of NPA are focusing on a group of young psychiatrists and residents. This is good to change the stereotypes about our discipline. Psychiatry evolves from isolation forms towards community psychiatry, and therefore the open door and minimization of use of these coercive measures is so important. I have nothing to disclose. And let me start with this is a controversy and a matter of debate, involuntary psychiatric treatment. According to WPA, the most important condition to justify involuntary treatment are when it is in interest of the patient's health and or it is necessary in order to avert danger to others. Of note, the concept of both patient's best interest and risk to others can be considered a variable and somehow unclear. The compulsory inpatient treatment and the use of various forms of coercion have spawned a debate concerning human rights and the ethical implications of applied procedures, not to mention their effectiveness. Many clinicians believe that involuntary treatment should be considered the last resort. Trauma caused by its use may disrupt the therapeutic alliance, create distrust in psychiatric care, and prevent patients from seeking help in the future. Such practices can also contribute to lowering therapeutic team morale and traumatize other patients and medical staff. This is a definition proposed by Swiss Academy of Medical Science. Also, it was presented by Silvana Galderisi during the Congress, virtual Congress in Budapest in June this year. So coercion means carrying out a measure in spite of the fact that the person concerned either indicates or has previously indicated through expression of wishes or opposition that he or she does not consent to it. In medical practice, force can only take a wide variety of forms, which ethical and legally acceptability varies across a continuum extending from imperative to completely unacceptable. And these are such forms like formal detention, treatment without consent, seclusion, or restraint or unsafe holding by other person. There is a taxonomy of coercion and compulsion along a spectrum. So from the beginning, persuasion, interpersonal leverage, offers, threats, and formal legal compulsion. Psychiatrists are facing the question whether involuntary treatment and the use of coercive interventions are compatible with human rights and do not violate the UN Convention on Rights of Persons with Disabilities. This committee stresses that compulsory psychiatric treatment and detention of people with psychosocial disabilities should be prohibited. It is postulated that compulsory treatment, isolation, coercive measures such as physical and chemical immobilization or forced medication should be abolished. It was emphasized that this committee promotes autonomy without taking into account the effect of mental illness on free will and information processing capacity, which is known to affect free will. Other clinician scenarios where decision-making may be impaired include acute conditions should also be considered. Limitation of the guidelines include situations where compulsory treatment can be avoided. So is it possible without involuntary treatment to meet the needs and interests of some services users as those with suicidal intent, of intent to harm others who refuse treatment? How should we deal with the issue of competing rights, preservation of life versus exercise of legal capacity, right to healthcare versus free treatment decisions? Here is the most common reasons for involuntary admissions according to EPA, published in European Psychiatry 2 years ago, so danger to other and danger to self. Of course, the coercive use measures in mental health care varies hugely. So there are differences in mental health services organization. There are differences in mental health laws. We are 44 countries in Europe. There are differences in social policy. There's also a local culture. And of course, the use of compulsion may change significantly over time according to change in policy and practice. There was a very important paper 5 years ago in the Lancet Psychiatry, article regarding suicidal risk and absconding in psychiatric hospital with and without open door policies. It was a 15 years observational study published by Huber, Schenneberger, and Andreas Heinz. The study lasted 15 years, and there were over 340,000 admissions in 21 psychiatric hospitals in Germany between the year 1998 and 2012. Over 140,000 patients were qualified for further analysis, and the assessment included occurrence of suicidal attempts, deaths by suicide, absconding with and without return across closed and open door wards. And the results demonstrated that the numbers of attempts and completed suicide or absconding with and without return were not increased in wards with an open door policy. The authors therefore put forward following conclusion: locked doors may not be effective in preventing suicide and absconding. So just summarizing it, the aggressive patient with coerciveness to the patient increased his frustration, fear. Also, it increased fear of staff. It lowered the morale, and of course increases the use of coercion. However, can we overcome coercive practices? There are, of course, intervention programs, especially the complex one, have proven effective in randomized control trials. So we know that there should be adequate ratio staff to users, and this staff should be trained and supervised. There should be an environment with according ward size, room size, colors, lighting, users and relatives involving planning, feedback from them, and also the use of risk assessment instruments, which contributes to lower risk of coercion. Also, the use of coercive practices should be monitored and become a part of evaluation of mental health services performance, and the good practices should be highlighted and rewarded. Andreas Hans, Mahler, and Lang advocate a reduction of coercive interventions and involuntary treatment to minimum. And they present a wedding model, which is actually oriented towards recovery and participation in treatment processes. This model was first introduced in Berlin, not far away from the place where I have my department of psychiatry. It's 120 kilometers, so a good example. And among its effect, they show significant reductions in patients' isolation, the use of mechanical protection, forced medication, and limitation of coercive interventions during the first 24 hours from admission to a psychiatric hospital. So very important, those first 24 hours. And as a part of this model, some guidelines were developed for sessions following the use of direct coercive measures. So these guidelines of wedding model, a post-coercion review session are. So the moderator should have some flexibility in conducting this session, but all questions should be asked. And those are what kind of direct coercion was used. So the patient described the situation in own words, the health professional and team members describe the situation in their words. Also, when patient's family and friends could be also present. Everyone present should express their feelings and perception of this situation, including the feedback from the team. Also, the question, what alternative to the applied coercive measure could have been used? What could prevent the use of coercive intervention that took place? So what can be done differently by staff members? And question to patients, could you as a patient react differently? The team should consider anything that could contribute to diffuse the situation. So the patient's need, anything that could contribute the so-called diffusing the situation, how and when the staff decide to end the coercive intervention. Is it understandable why exactly the decision was made to end the coercive intervention at that particular time? Also, looking back, does the patient understand the reason of use of coercion, and does he understand that the staff felt powerless, unintimate, or scared? And as a staff member, questions to the staff, if they understand the decision, why the coercion was made, and why the patient was aggressive, intimating, or tense. Is the future cooperation possible? This is also a very important question for the patients. What could be done for a successful cooperation during and beyond hospital treatment? And of course, same question towards staff member, building perspective. So can the conclusion of the session be used to establish a contingency plan for future therapeutic alliance concerning further treatment? So we come from the open door policy comes from hospitalization towards hospitality. So there are, from one side, we have institutional rules, institutional time, relations, time of crisis disconnect from ordinary life, stronger patient role, and minimum network inputs. On the other side, open door, agreed flexibility rules, mediated time according to user needs, relation tend to break rituals, a person in a context, and a maximum co-present of social network. So this Werdinger model, minimizing the use of coercion and the open door policy, are in line with the Bioethics Committee of the Council of Europe, and they constitute important part of activities of European Psychiatric Association aimed at establishing principle of good practice, voluntary practice care, and professional treatment procedures, what was described by Meryam in her talk. Here are some examples also of Polish hospitals. It was a huge hospital in Warsaw. They simply, it was in Warsaw, and the conclusions were that 18% within 1 year of patients, hospitalized patients, the direct coercion was used, and the high probability of use of direct coercion was applied during the first 24 hours. It was much more often during the night shifts, and when the patient were direct sent from the ambulance to the inpatient clinic. Another example from Institute of Psychiatry in Warsaw. Here was 1 year observation. 15% of total number of admissions were the involuntary psychiatric holds were used. It was mainly patient with schizophrenia, women more often, and again it was the doctors who decide the admission of the patient against his or her will. That was the starting point of all other increasing of the coercions. I also want to turn your attention to the publication from 2020, the compulsory admissions of patients with mental disorder, state of art on ethical and legislative aspects in 14 European countries. This is the paper by Danuta Wasserman, but also co-authored by 40 presidents of associations with huge number of informations about the law and state of art of these aspects in Europe. Also, I want to stress that we have translated the codes of ethics in Poland, and Polish Psychiatric Association acknowledge it as well, and we already organize meetings where these things are discussed to implement these things. So the discussion is the good of the individual versus the good of all. Can we respect human rights versus safety? How to minimize the use of coercion? And of course, open door psychiatry versus acute states. For my final remarks, I want to stress that the implementation of alternatives to coercion is needed to improve the quality and safety of mental health services. And the evidence-based effective interventions are available, but not largely implemented. And there is still a huge work needed to adapt them in different contexts and cultures. With this, thank you very much for your attention.
Thank you very much to Jerzy and to all our speakers to be in time. We have enough time now for discussion. Thank you very much, Jerzy, for underlying the open door policy and minimalization of the use of coercion measures, for example, using the Bedinger model or other alternative possibilities. So regarding also human recognizing and awareness of human rights and involuntary treatment issues. So there is a lot of slot or space to reduce coercive measures and treatment possibilities. And there are, I understand, really evaluated or very important alternative possibilities to be implemented or to be used, not only in Germany, looking to Bedinger model, but also in other parts of the European countries. So thank you very much. It's very interesting to have so much information. We have now time for comments and questions, and please get back to us and ask us questions, discuss with us, and of course, we are very happy to do it with you. And I invite, of course, Özge to share this session together with me. Would you like to start, Özge?
Yes. So we have a number of questions. Our first question is from Giovanni Dalla Valle and is on the topic of the issue of increasing pressure on digitalization in patient-psychiatrist relationship. Digitalization is becoming a huge problem, not only for technological limits and obvious discrimination of patients, carers that struggle with access to digital devices. It is also for cognitive and emotional implications, which result in disruption of patient-therapist therapeutical relationship and eventually harm to patients. Expecting patients to abide to artificial intelligence algorithms and so inevitably limited range of choice in their response goes to de facto against WPA and EPA ethical principles that defend patients' autonomy. Also, artificial intelligence programs are designed by a very restricted number of IT workers, nearly always not doctors, not professionals competent in our medical matters, and are sold for profit of even more restricted number of software companies, usually big tech companies like Microsoft and Apple. Can you see the plethora of ethical problems generated by this very simple fact? I would like to ask if one of our speakers would like to answer this question.
Silvana, would you like to start and then I follow? Thank you.
Well, yes, this is a very important, complex question. Thank you very much, Dr. Della Valle, for asking about it. I have to say that although I think that most of us share your concerns about the dissemination of this kind of practices, we also have to recognize that the fact that we have concerns should not mean that we are going to object or to reject altogether the issue of digitalization. The reason why I'm stating that we cannot simply reject the dissemination of this kind of practices is because, as a matter of fact, in many contexts, they can be extremely helpful. Let me start from the example of COVID-19 pandemic. I think that without digital tools, we could really never keep all of our therapeutic relationships with our patients at that time. The lockdown meant for many of us immediately endorse also the practice of exchanging messages on the main apps. It meant giving our patients the possibility of reporting their needs and symptoms via digital tools, and therefore we cannot reject all the practices based on digital tools overall. Also, I would like to remind Dr. Della Valle that, as a matter of fact, there are places in the world where it is extremely difficult to access the mental health services. There are people who live in remote places, and the access to mental health services via digital tools can be the only available option. And I think that an option with some limitations should be preferred to nothing. Also, we cannot be so general in mentioning digitalization, because digitalization means so many things. I just would like to provide another example relative to cognitive rehabilitation. We, in my department, we think that, for instance, cognitive training is an important tool for many patients who need to improve their cognitive functioning. And we had the experience that for many of them to come to our department once or twice per week could be an unbearable burden for their families to accompany them, for themselves to support some costs for participating in the in-person encounters could have been cumbersome on the long term. Of course, starting with the in-person meetings and continuing across time with the remote access to the cognitive practices has been a very, very important advance. And so there are now some training programs which also allow this kind of mixed model, part of the training sessions in person and part of the training sessions for remote access. So I think that we should not generalize. I don't think that digitalization is going to replace our encounters, is going to be a sort of general substitution for the personal encounter, but is an additional tool. And as such, it should be regarded, improved, regulated, because this is an extremely important aspect, that when we start by saying just no, means that we are not even going to make it better and to regulate it as needed. I would stop here and listen to the other colleagues' opinion.
Thank you very much, Silvana. I would like to add, I have seen you, Jerzy. I would like to add that we have a lot of apps, for example, to treat, for example, depression or for psychoeducation and so on. And if we have data protection issues respected and also ethical aspects before the approval of these apps, for example, it's very helpful for our patients for suicide prevention issues. There are also a lot of issues. Furthermore, we use a lot of tailored psychotherapy. For example, there are networks in which colleagues treat patients in other countries, other parts of the world, for example, in their languages and so on. And if they use these possibilities regarding and respecting all protection issues, and informed consent is given by the patients, and of course it is a decision-making process between patients and these colleagues, it is a great additional possibility to widen our horizon and our treatment possibilities. Another additional issue is, which I would also like to add, is the use of interpreters, for example, via videos or video consultations and so on. So therefore it is a very good possibility to use digitalization and so on. But in case of our own privacy, for example, using social media and so on, these are also digital media. We should be very careful as psychiatrists or medical doctors, because we have to be aware of our boundaries and so on, and privacy and so on. So this is a huge topic. We should discuss it controversially and also going on with our discussion. So I stop here also, and Jerzy, you would like to add something?
Yes, thank you, Meryam. Of course, digital technology might offer psychiatry the potential radical change in terms of service delivery and the development of new treatments. Of course, it also carry the risk of commercialized, unproven treatments entering the medical marketplace with detrimental effect. But psychiatrists need to remain up to date, educated in the evolving digital world. And I want just to mention that in the Council of NPA, we have a task force proposed by EPA President, digitalization in Europe, to update the psychiatry to the digital century. We have performed a survey which was over 36 NPAs answered it, so it will close the gap in European psychiatry. We would know the current status of digitalization in Europe in terms of laws and main working places, what kind of mental health tools are available in European countries. It varies from country to country. So this is another issue. We can make another webinar on this topic. I hope that soon it will be the paper on this, and it could rise a discussion, further discussion. Thank you.
Thank you very much. Özge, would you like to add something regarding early career psychiatrists? Do you know how our young psychiatrists are thinking about this topic? digitalization. It's we older ones are maybe not so familiar with a lot of digital issues, but the younger psychiatrists are very well involved in these topics.
To my opinion, I think early career psychiatrists are very open to digitalization in psychiatry, which doesn't mean that ethical issues and ethical dilemmas will not appear. I think this is a topic, this will be a topic of controversy for a long time, but it looks like it will be in our practice for a long time too. But I can say, at least to my experience, early career psychiatrists are open to practice it. But of course, many of us are also a bit concerned about the issues related to digitalization.
Okay. Thank you very much, because it's a huge topic and there are a lot of possibilities for misuse and so on. So therefore we should also be very careful with information about our patients and so on. Thanks again. Would you like to go on with the next question, or should I do it, Özge? Okay. The next comment is a comment from Gwyn Crawford. Congratulations, very interesting. I'm very sorry that I need to leave now and join another work meeting. That's a pity. You couldn't join our discussion.
And another question from Vincenzo Giordano. In 2022, is it important to destigmatize assisted death if the quality of life of a human being is annihilated by an illness? Wouldn't it be more detrimental to keep a human being who is suffering alive just for the sake of Western patriarchal normative societal rules?
This is a very difficult question. According to our EPA Code of Ethics, we said that we are as psychiatrists, or we do not have the duty to take part in such kinds of processes. Silvana, what do you think about this question? Destigmatize assisted death?
Well, I mean, I think that as before, here too, we have a little bit of a misunderstanding. I just would like first to go back to the question we discussed before, because the colleague says that he did not mean to suggest rejection of digitalization overall, but I don't think we assumed that he meant rejecting. We just warned about avoiding rejection overall and suggested that, of course, some regulation is needed and also an in-depth ethical reflection. So I don't think that we are indifferent or in a very discrepant position, but simply that we did not very well understand each other. Here too, I think that we did not mean to suggest that assisted suicide is against, we are against assisted suicide. We were just pointing out that our code of ethics at the moment suggests that for psychiatrists, the involvement should be limited to define whether the request of life termination is based on a mental illness that can interfere with the decision of the person, with the real willingness of the person to terminate her or his life. So in my opinion, these are two different topics. One topic is assisted suicide that, of course, I think that in each country, and especially in Europe, is nowadays a very hot topic and is in need of regulation, but of course is not, no one, at least for what I can tell about medical profession in general, most of us are not against assisted suicide in conditions in which we have pain, severe illnesses that cannot be treated in any way, where there is no hope for the person and there is only suffering ahead of the person. The other case is when, for instance, a person with a very severe depression is asking for help with suicide. In these cases, we as psychiatrists convene that we should not take part and should not accept the request, because it is in our experience that most persons, when the depressive episode or the psychotic episode is treated and the person is in remission, the person is thanking us for having helped to overcome the crisis, the depression, the psychotic episode, and is now back to life, happy to be back to life. So that's why we, as psychiatrists, up to now, we maintain that for us it's very important to treat the disease instead of simply saying, okay, the person is asking us to be supported in her or his suicide ideas and attempts, and we take the attitude of a therapeutic attitude and not an acceptance, a passive acceptance of the request.
Thank you very much, Silvana, for to clarify here. It's very clear. I would like to ask also Dr. Bienkowski, did you have in your survey in the preliminary data some points regarding also assisted suicide or yes, assisted suicide or death by suicide? And what did the colleagues or National Psychiatric Association give as feedback?
Well, a very complicated question and a very simple answer. Our topic was not to assess any attitude towards assisted suicide among European psychiatrists. We just identified assisted suicide as a kind of topic for current and future debate, especially in Western countries. I can imagine this is also a hot topic in Eastern countries and in all over Europe. My personal impression is that this is the topic mostly for discussion at the level of the whole society. That should be the process initiated within society and not within only medicine, and for sure not within psychiatry as a starting point, because psychiatry can easily be in a very critical position of judges, judging whether the person should or should not be allowed to commit suicide. That's probably the worst idea for psychiatry, to be this critical point in the whole system. I think the level of the discussion should be more general, and the level should be more political and at the level of the whole society.
Yes, thank you very much for these comments. I agree totally. It's not our topic. It's a topic of the whole society and of our whole life. Yes, thank you. So, Özge, would you like to go on? You are muted.
Sorry, of course. So we have another question from Amina Rabat. Thank you, Dr. Samochowiec. I agree with many of the principles of minimizing coercion. However, when a person is acutely unwell and maybe unable to reason, how can the model, which assumes a person can reason and negotiate, be implemented?
Yes, thank you. I want to stress that this Wedinger model and guidelines of conducting post-coercion review session. It means, of course, if there is a need and there is a danger to self or danger to others, this does not mean that you negotiate in this moment. This is just how to perform further, how you can minimize that and discuss with patient what happened. It means that the staff is well trained and then also is involved in planning, have feedback, and there are risk assessment instruments. So everything is monitored and discussed. So this is simply how it works. Of course, when there is a ward where the one doctor for 100 patients and 2 nurses for 25, it's very crucial to have enough number of patients. I remember in Berlin there are even students who are getting work as members that stay with patients to talk with the patient with suicidal thoughts, and if you don't have this staff, you just you are forced to use other coercive measures. So this is how it works. So again, this is the post coercion status which I discussed. This wedding model is regarding that. Correct me, Silvana, if I am wrong. It was used in Berlin. We were introduced to this model. In 2020, we were even thinking about implementation of this model, although then the COVID came and we were designed as to be a station for psychiatric patients with COVID. So this was extremely difficult situation at the beginning, but that's why it was prolonged. But nowadays we are getting our territory. We are being a part of so-called pilotage. So we have a territory which we from this isolation. There's a transition time that over 1/3 of Polish inhabitants will be covered by community psychiatry. And I hope that this will be kind of reason how to use and why to use those techniques. Thank you.
Well, if I may add, thank you, Jerzy. I think I agree with most of what you said, but also I would like to address more specifically the question of our colleague, meaning that, of course, the reason why we generally talk about the possible alternatives to coercion and not about the elimination of coercion is because we are fully aware of the fact that coercion can be dramatically reduced, but we are not sure that it can be eliminated. So at the moment, there are some institutions and some groups who claim about the possibility to eliminate, but most professionals do believe that it should be a tool to use in very extreme conditions, in those cases where we are totally unable to provide a different approach. Now, the colleague says, Amina says that when a person is acutely unwell and may be unable to reason, well, what Professor Samochowiec said about the possibility that there are people who talk to the person, who provide reassurance, who can put in place different tools and not coercive tools, we are able many times to avoid coercive hospitalizations, coercive administration of drugs, and even physical mechanical restraints, which are to be avoided as much as possible. This is probably the thing where we should go to the elimination, because I think this is the most traumatic for people. But if we are able also to avoid coercive hospitalization, this is an important step. And for many patients, we can see that when the approach is as soft as possible, is not confrontational, but it's really oriented towards a discussion, a reciprocal understanding of what's the matter, what took the person to the mental health center or to the hospital directly, who was involved, which events actually made the person feeling acutely unwell, what were the stressful factors, and so forth. In many, of course, not all the cases, you can have a possibility to negotiate. And in many cases, you can even avoid the hospitalization or have a voluntary one. So these are the points. So the fact that a person is acutely unwell and apparently unable to reason doesn't mean that we simply assume that the person needs coercive measures. These two things are not equivalent.
Thank you very much, Silvana. We have more questions and comments. Maybe we should go on. And the next one is, hi all, what about patients who are in danger to self and they refuse to admit it to psychiatric unit? What is the best approach to deal with those patients? So maybe this is also a question to the audience, to all of you who would like to get back to this question. Most of the aspects, Silvana, you have mentioned, but also Jerzy has mentioned. So is there anything to add? Seems not. Davala, please, Özge.
So if I think we can continue, we have 4 minutes. Maybe we can have one comment and one question. Mm-hmm. And there is a comment from Hilal Altundağ Duru. She wrote a master's thesis on malpractice in psychiatric clinics. Thank you very much for the valuable webinar, a significant subject. Thank you. It's very interesting, and I assume, I'm sure that you have put a lot of effort and commitment to this. I wonder whether it's open access to read. I think it's very valuable. Thank you for your comment. And we have one more question from Wojciech Kozmowski. One very difficult issue is how to behave when ethical standards are different. For example, assisted suicide according to EPA, WPA, or Polish Code of Medical Ethics. I think this may be a question for all presenters, if you have anything to say.
Well, I may start by saying that once again, the difficulty of sharing some hot issues is something that requires time. When I say that, I think that many professionals are not against assisted suicide in cases in which we are in front of a disease that is very severe, is causing a lot of pain. I think that there are some doctors that may be against for their ethical, religious beliefs, but still many professionals would be in favor in those cases in which there is no hope. Now, whether there are differences among different medical doctors, this is a fact, but this is also true for abortion, for instance. And in Italy, when abortion was legalized, of course, there were doctors who were against, and these doctors were given the possibility to abstain from the practice of abortion. And I think this is an important reason, an important issue, because people who have different religious or ethical beliefs should be free of endorsing those principles. But still, ethical codes should take into account the majority of the people who think that this should be an issue that is addressed. Once again, this is not specific of psychiatry, and I agree with what Meryam said, Jerzy said, and I think also all of us agree that this is not specific to psychiatry. Psychiatry is called to say whether psychiatric disorders should be a reason for assisted suicide, and overall, we think that this is not the case. As to the other medical codes, ethical codes, this is another topic that is not in our hands.
Silvana, we have to stop here because our time is limited and we are at the end of our webinar. Thank you very much for all of you speakers and for my co-chair Özge. Thank you very much to the audience for your comments, for your questions. I'm very sorry that we couldn't get back to all of you with your comments, to discuss your comments and your questions, but I hope we will have other platforms where we can have exchange and discuss these very, very important topics.